Hello, everyone. Welcome to today's webinar. We're just going to give a second for folks to join here, and then we'll get going. All right. Hello, and welcome to today's webinar. My name is Elizabeth Angel. I'm EERI's Communications and Program Manager, and I'm delighted to have another webinar in our series showcasing highlights from each issue of our peer-reviewed journal, Earthquake Spectra. This will focus on two great papers from the November 2024 issue. Before we get going, I just want to take a brief moment, if you're not already familiar with the EERI, to let you know a little bit about our organization. The Earthquake Engineering Research Institute is the leading nonprofit membership group that brings together professionals from a wide range of backgrounds and disciplines, both researchers and practitioners in the US and around the world, who work together on the shared goal of better understanding earthquake risk and increasing earthquake resilience in our communities. So if you're not a member, I hope you'll look us up and consider joining us. If you are a member, remember to renew your membership for 2025. And check out our website to find out more about the great work that we do. I also want to briefly acknowledge that this webinar series is supported by funding from FEMA, by our Learning from Earthquakes Endowment Fund, and by EERI members. So you guys make our work possible. I also want to take a moment to acknowledge our EERI subscribing members, especially our visionary subscriber, Computers and Structures, Inc. These firms also help make both this webinar series and many of our other activities and events possible. You can find out more at our website, and if your firm is interested in supporting EERI and being involved in the work we do, you can learn how to do that there. Finally, just a quick mention that we have a couple of upcoming webinars. One is coming up in February. This is going to be around a number of things coming out of our Learning from Earthquakes program around the 2-year anniversary of the devastating earthquakes that affected Turkey and Syria on February 6th, 2023. We had a follow-up reconnaissance team go jointly with the Social Science Extreme Events Reconnaissance Network to Turkey in October to look at recovery, reconstruction, housing issues. So they're going to be sharing the preliminary findings from their team. And you can register for that on our website. And we don't have a registration link available yet, but coming up this spring, we're going to have a great webinar series with folks from the United States Geological Survey looking at the 2023 National Seismic Hazard Model. And that's actually going to include a number of paper authors from another Earthquake Spectra special collection about the hazard model. So we'll be looking both at the science underlying that, but also at the implications for engineering and practice. So stay tuned for more information about that. And on that note, I'll turn it over to today's moderator, Carlos Molina Hutt, who's an associate professor at the University of British Columbia and is also one of the associate editors at Earthquake Spectra. Carlos?
Yeah, thank you, Elizabeth, and hello, everyone, and thank you for joining. As you just heard, I'm going to be moderating this session, and the only thing I want to remind you of is that you write your questions and submit them using the Q&A feature as they come up during the presentation, and then we'll have time at the end of both talks for a little bit of Q&A with the presenters. Some of you might, naturally gravitate towards the chat, so the reminder is to use the Q&A feature because that's where I'll be moderating or keeping an eye out for the questions. Can we go to the next slide, Elizabeth? Thank you. Before we get started, I wanted to remind everyone that we have a special collection on forward-looking, equitable, and systemic earthquake risk modeling. There are a number of topics that are covered in this special collection, including methods for time-dependent earthquake risk assessment, network-level earthquake risk modeling, and multi-hazard or cumulative risk analysis, as well as the development of equitable risk metrics. So if you have any work on these topics, the submission deadline has been extended until the end of March. So we encourage you to submit your work to this special collection in Earthquake Spectra. And you have a QR code there, and I think Elizabeth is going to post a link in the chat as well. So with that, we can now move on to introduce today's speakers. We have two speakers lined up for you, Yvonne Merino Peña and Lukas Bodenmann. And I want to point out briefly that this is a truly global webinar. We actually have Elizabeth joining from California. Yvonne is currently joining from Colombia. Lukas is joining from Switzerland, and I'm actually joining you today from Auckland in New Zealand. So we are all over the place here. I'll briefly introduce our first speaker, while she gets the slides ready, and then I'll introduce the second speaker as we transition from the first to the second presentation, and then Q&A will be for both talks at the end. So our first speaker is Yvonne Merino Peña. She is currently a PhD candidate at Pontificia Universidad Católica de Chile. Her research focuses on seismic risk and resilience of emergency healthcare networks and facilities, as you'll see in her presentation. And during her PhD, she spent some time as a visiting scholar at New York University. And she's also worked as a research fellow for CGDEN, which is a research center for integrated disaster risk management in Chile. So with that, I'm going to hand it over to you, Yvonne. Thank you.
Yvonne, can you turn your sound on?
Great. Hello, everyone. Thank you very much, Carlos. Thank you, Silvana and Elizabeth, and all the Earthquake Spectra team for organizing this webinar and for the invitation to present our papers. Can you hear me? Okay.
Yes.
Yeah, you're fine.
Yeah, thank you. Thank you. So today I'll be talking about what we have learned of modeling hospital resources using epidemiology data on earthquake-related disasters. I'm very pleased to share that we, the authors, and all the professionals who contributed to this research, who contributed to this research come from very diverse disciplines beyond earthquake engineering. So it's been an incredible, fruitful experience for all of us, and I want to thank all of them for all of the support. So first, I'd like to say that when we talk about human consequences of earthquakes, we often think of casualties in terms of mortality and morbidity. But in addition to the death and the injured, there are also those who are physically and psychologically affected, as well as individuals who have lost their homes and seek support in emergency facilities after earthquakes. Actually, these groups are often interconnected because in many cases, access to healthcare significantly impacts the final death toll. So this is very important because different types of victims demand different types of resources for an effective emergency response. So we can consider the number of deaths and the injured individuals as the immediate consequences of earthquake disasters. As illustrated in this figure, Asia and the Americas have recorded the highest number of immediate casualties from earthquakes in recent years. And also from the literature, we know that some of them have also triggered the most affected people among all the recorded earthquakes. So for you to have a reference, in 1985, an early estimate suggested that a ratio of approximately 1 to 3 for people killed to those injured in large earthquakes was 1 to 3. This ratio can vary significantly, but it generally remains about 1 to 3 or 1 to 2. So for this research, we have focused on injured people, as they are the main demand in hospital services after earthquakes and resources. In this plot, the bars represent the 12 earthquakes with the highest toll of injured people reported by EMDAT. We can see that Asia and the Americas lead in the number of injured, consistent with the data on fatalities that I showed you in the previous figure. So please notice that the earthquakes in 2008 in China and 2010 in Haiti have reported a significant number of injured people, even exceeding other earthquakes with high intensity too. So we aim here to understand how this data on injured can inform our hospital models. So the issue is that the injured people demand acute medical care in hospitals, but they face two challenges after earthquakes. Firstly, they experience physical damage that can reduce the functional capacity of their service areas. And second, hospital experience a surging demand for emergency treatment. This leads to a sudden increase in the need for medical services and resources. These two factors create an unbalanced scenario for assisting incoming patients. So this is why we wanted to answer what are the consequences of losing hospital areas on the treatment of injured people. And to address this question, we first need to understand how are the earthquake injured and what are the medical treatment that are typically required for those injured. So we've learned that it's all about time. In this hospital record, we have a quick example. So during earthquake emergencies, everything unfolds rapidly, like the injuries on the people due to infrastructure damage, the arrival of victims to hospitals, the worsening of death conditions in trapped victims, and the risk of medical complications for the injured victims. So in this quick example, they recorded the early arrival of injured to the hospitals, and you can see the worsening of patient outcomes for those who reach the hospital after the first day, that it's like the most critical day. This is a very quick example for Turkey earthquake, and we'll go deeper in this. So hospitals are very complex systems that exhibit a dynamic queuing behavior. They are often studied stochastically due to the variability of their several components. There are some examples of the dynamics of hospital facing earthquakes. This is an example for the 2011 Japan earthquake. So hospital operations models are based on numerical simulations that help us understand the processes and resources involved in the treatment of patients and help us track queuing times of patients that we also know as patients waiting times. To build it, we build a hospital operations models using discrete event simulation, which are particularly focused on tracking the times needed to complete a set of processes for every patient within the hospital. And to build it, we work on these two components. First, we studied the health profile of the injured and how the injured arrived to the hospital. And second, we analyze the medical processes needed to treat these patients. So here it's essential to mention that the approach to defining these processes was based on the relationship of every process with the physical resources supporting each medical service. That's very important. This means that we assumed that human resources are available as they are imperative for the operation of the hospital services, so we didn't model that. Second, oh, sorry, I was here. Second, we analyze the medical process. Oh, sorry, this is a different one. Sorry, I go back. There, it's okay. Well, characterizing the injuries of earthquake victims has been a great effort over the past few decades. And previous models for hospital have used such data to simulate emergency operations under earthquake scenarios. But these models can be updated since we have recorded more and more data from recent earthquakes. So on the same plot that you saw earlier, we now highlight the events for which we have new data on post-earthquake epidemiology. Bars in white represent those events with very little or no data, and bars in gray indicate the events for which we found interesting data about injuries and illnesses that haven't been included in previous models. Finally, we have events A and B, the Loma Prieta and Northridge earthquake in California. And these two events have been used to model hospital response after earthquakes in previous models, and have also been useful for casualty estimations, such as those employed in Jesus. So there's a wealth of interesting data from emergency medicine recorded after recent events that can be used to inform and enhance our hospital models. It's slow there. So we analyzed this new data and identified 7 patient types or patient profiles, and we focus on those with immediate and urgent health conditions. We reviewed several papers on emergency medicine and highlighted common types of injuries and illnesses. A relevant aspect, again, of these proposed profiles is that each of them is suspected to require a different set of physical resources for medical treatment. As you see, most profiles are related to trauma, and a smaller percentage come from the renal and from the medicine specialties, such as the last 2 profiles. Also, the most frequently reported health condition was surgical injuries in the extremities, such as, for example, open limb fractures and soft tissue injuries. So in the paper, we have included an interesting and detailed description of each injury profile, and we also included data sources and the associated resources reported by the emergency medicine. Now, our goal is to model the arrival of these groups of patients at the hospital after the earthquake. But before this, we need to randomly generate the arrival times. So we used a Poisson distribution to determine when a new arrival occurs. As you can see on the left, we first defined the patient's arrival rate function, which describes the dynamic behavior of the arrival rates after the earthquake. And you see from the axis that we simulated the hospital operation during 2 weeks following the earthquake. And we consider that the surge in demand will occur only during the first 7 days, during the first week, based on data from previous earthquake. For example, if we expect a total of 1,000 patients during the first week, we anticipate 500 patients on the first day. This means that we'll have a peak rate of about 20 patients per hour, which then decreases with time during the first week. So for step 1, we generate the patient arrivals, and in step 2, the model randomly assigns a specific patient type to each arrival. And for step 3 is about that model component of processes. So this is what happens inside the hospital. We model simplified emergency medical processes for a tertiary hospital. It means a hospital that provides specialized services such as hospitalization, intensive care, dialysis. And as shown in this diagram, every patient type that you see from 1 to 7 follows a distinct path through the hospital services. So each path covers a unique set of processes or a unique set of procedures that are performed in specific areas that you see in the shaded box in the upper side. And finally, each procedure is represented by a probability distribution. Every of these boxes representing procedures are associated to a probability distribution to account for the uncertainty in procedures time. So these resources that you see with double mark border indicate those processes with specific data on earthquake emergency that have been recorded during earthquakes. The other procedures are just used in baseline conditions data. To build these simplified processes, we leverage first on the experience of the authors whose experience on emergency medicine, and then we conducted as expert elicitation with professional staff from hospital and international institutions such as Pan American Health Organization, with expertise on disaster response. So please notice that patients types 1 and 2 pass through the emergency department services only. So we call them ED level patients, and the rest of them will be called hospital level patients. Our model was designed to calculate 2 key metrics: maximum values of patients' time to treatment and unassisted patients' radio. Time to treatment includes the total time since the patient arrives to the hospital until they start receiving any treatment. As you see in this figure, we recorded the time to treatment of the last patient in the Kiwi for every patient type, every minute. So we got this curve in brown that use time to treatment in time. Then we gather these big values for all the simulations. So it means the point in time to treatment that you see in moment B. That's a moment of peak crowding, and plotted the density functions as you see in the last box on the right side. We also tracked the number of patients whose time to treatment exceeded a specific time threshold relative to those patients in the queue. This time limit varied between ED level and hospital level patients, and it was derived from international standards. So this is how we calculated the unassisted patient radio. So we applied our model to a large public hospital in Santiago. This is a base isolated hospital and the second in size of the subnetwork that serves the southest population of Santiago. So it is expected that it absorbs the emergency demands if the surrounding facilities become inoperative after earthquakes. For the simulation, we considered a twofold increase in regular demand, and the resource capacity was assumed to be fully available at the emergency department and 75 bed occupancy rate for the hospitalization, services. Oh, sorry. Well, we ran Monte Carlo simulations for 2 weeks following the earthquake and monitored the patient's waiting time with a resolution of 1 minute. So 1,000 Monte Carlo simulations were performed to get average curves for time to treatment for both ED level and hospital level patients, ED level on the left and hospital level patients on the right side. And we calculated distributions of maximum time to treatment. They highlight the significant hospitalization times for hospital level patients. And for patients 1 and 2 who do not require surgical procedures, the mean time to treatment ranges between 4 and 7 hours. That's very good. That's relatively very good. In this model, ED level services are represented by time distributions with means below 30 minutes. So as perhaps expected, the flow of the non-surgical patients is significantly faster. We also noticed that for hospital-level patients, the mean of the distribution is very similar, despite involving different procedures. Again, maybe this is likely due to them relying on the availability of bed and ICU. We proceed in the same way for the unassisted patient radio. We calculated average curves and compared the trends. And the results also demonstrate again the significant impact of hospitalization times. And unlike the ED level patients, the unassisted radio remains increasing even after patient arrival cease. You can see them in the shaded bars. This is again due to the long processing times. But the most interesting exercise was simulating the impact of resource availability on each type of patient. So we used time to treatment distributions to see how increasing capacity enhances the hospital response. We computed the distributions after varying the number of examination rooms and beds, a number of beds, as they are the most shared resources. We found how ED level patients are more impacted by the changes in examination rooms, and hospital level patients are more impacted by the number of beds. That's a bit expected. But it's not linear, as illustrated in plots A and B, despite the linear change in the resources. I think I'm going to skip those two plots that are very interesting, that I'm getting out of time. So we learned that for the distribution of patient types that we use in this research, the examination room is key for all types of patients and significantly impacts ED level patients. And this is very interesting because we could validate this relevance through the observations in hospitals during a post-earthquake reconnaissance to healthcare facilities after the 2023 Turkey earthquake sequence. In the photo, we captured some patient tags pasted in the wall as spaces for examination of patients were insufficient during the first days after the earthquake, and patients were located in the corridors. We also found that treatment of surgical patients, that it's the most of the immediate patients we consider, relies on the available hospitalization beds for recovery, and thus restricts the flow of the response. And these two final conclusions, to keep in mind, response metrics do not vary linearly with the addition of resources. That's very interesting to account for the relevance of these types of models, and the accurate estimation of the expected patient times of the real calculation or estimation of the treatment capacity in hospitals allow for effective preparedness and responses, as they can give you an idea of the time you have to be prepared for the crisis. Sorry for those 3 minutes, Carlos and Lucas. Thank you very much, and thank you to all the co-authors and the advisors.
Thank you, Yvonne. That was great, and no worries. I'm sure we can make up for those couple of minutes. So as I mentioned at the beginning, the Q&A is something that we're going to do at the end of the two presentations. So again, I want to encourage you to use that Q&A feature. We have two speakers. I didn't say it earlier. So when you're writing your questions, please specify if the question is for Yvonne or if it's for Lucas. And I see he's already sharing his slide. So I'm going to briefly introduce him. Dr. Lukas Bodenmann is a climate risk scientist at Climada Technologies, where he specializes in risk assessment of spatially distributed systems exposed to natural hazards. He did his PhD at ETH Zurich and focused on spatial ground motion correlations, empirical fragility modeling, and rapid post-earthquake loss assessments. And you'll see some of his work very soon. He partly did part of his research as a visitor at Stanford University. So with that, over to you, Lukas. Thank you.
Thanks, Carlos, for this kind introduction, and thanks to EERI for the invitation and the opportunity to present in this webinar. As Carlos mentioned, this talk is going to be about empirical seismic fragility model and how to account for ground motion uncertainty in doing so. This is joint work together with Professor Baker and Professor Stojadinović. And as probably most of you know, fragility models aim to predict physical damage as a function of a ground motion intensity measure, which I call IM in the following. And typically, they are illustrated in terms of fragility functions, stating the probability of reaching or exceeding a certain damage state conditional on an IM value. Here in this example on the right, we use 3 qualitative damage states that describe the overall damage to a building structure. Now, in this talk, we're going to focus on empirically derived fragility models, which were estimated based on damage data collected after previous earthquakes. And estimating models from such data is challenging because typically the actual ground motion intensity measure is unknown and needs to be estimated. Thus, if we observe, or when we observe a damaged building, we typically don't know whether it was damaged because it was weak, or because the actual IM was larger than the estimated value, or because of both. And in our paper, we aim to investigate this causality dilemma, or this chicken and egg problem, if you want. And having said that, I would like to further illustrate this issue using this one-dimensional example of a quite boring city that consists of 500 buildings located on a line between -20 and 20 kilometers. And those buildings are subjected to an earthquake located in the center of the city. And the black solid line in the bottom plot shows the ground motion intensity measure value at the locations of these 500 buildings. Then we also assume that this intensity measure was observed with 2 seismic stations. Now, let's look quickly at the data generating model behind. So what we have is essentially, we started with some rupture characteristics, that is the magnitude and the location of the earthquake event. And then we used ground motion models and spatial correlation models to simulate intensity measure values at the sites of the seismic stations and of the buildings. Now, in the next step, we assume some true parameters of the fragility functions based on which we simulate a damage state for each of the 500 buildings. And in this example, we again use 3 possible damage states, and the assumed functions are shown here on the right. And the plot in the bottom, in the top left, shows you the resulting damage states for each of these 500 buildings. Now, with this damage data set, we aim to investigate whether we are capable of recovering the true or the assumed true fragility functions that I've shown you before. And for this purpose, we're going to apply 2 parameter estimation techniques. First, the state of the art, which we call the traditional approach, and then a new approach that we proposed in our paper. And this slide also highlights the previously mentioned challenge, namely that the available information is actually quite sparse. So if we look at the problem statement again in our probabilistic model, I now filled the circles of these variables which we assume to be observed in gray, which means like the rupture characteristics, for example, or the IM values at the seismic stations, while those variables which are unknown are still in white, and those are the IM values at the sites of the buildings and the parameters of the fragility functions. Now, in a first step, and this is common to both approaches, we estimate the intensity measure values based on the ground motion model and on the observed intensity measures at the seismic stations. So this is essentially what is being done in shake map systems that produce these maps of intensities after earthquakes. Yeah, and if we look in our one-dimensional example, what we see here is the dashed gray line shows you the predicted median intensity measure value, and the shaded area shows you the 5% and 95% quantiles of the predictions to illustrate the uncertainty. And we see how this uncertainty is reduced close to the locations of the seismic stations, but also increases with distance to them. Now, in the traditional approach, or the state-of-the-art approach, we typically assume that the intensity measure at the location of this building is fixed to the median predicted intensity measure. That is, we assume that the median intensity caused the observed damage. And by doing this assumption, we can then use maximum likelihood estimation to estimate our fragility models. And the resulting functions are shown here on the right. Now, if we compare these functions to the true functions that were used to generate the data, we observe that the estimated ones are flatter than the true functions. And flatter functions means that we are less sure which IM value causes a building to reach or exceed a certain damage state. In other words, it indicates that the estimated functions have a higher dispersion than the true functions. And this can be explained by looking on the left-hand plot. By assuming or by using the median prediction as a fixed best estimate, we don't allow for the possibility that the actual IM values, so the solid black line, can be stronger or weaker than this median estimate. Now, if we go back again to our probabilistic model, we see with this approach essentially allowed us to decouple the upper half of this model from the lower half. So essentially, an analyst can use standard outputs from a shake map system, which is these median IM values, and then use those as a fixed covariate in a statistical model to derive the parameters of the fragility functions. However, this has the downside, as we saw, that the estimated functions tend to overestimate the dispersion of the fragility. Now, in a new approach that we proposed in our paper, we look at the coupled model and we consider both the intensity measures at the building sites and the fragility parameters as uncertain random variables, for which we specify prior distributions. So for the intensity measure on the left, we take the prior distribution from our ground motion model. That is, we do not only consider the median, but the entire distribution around it. While for the fragility function parameters, we assume weakly informative priors that allow for a certain flexibility to consider building types of different resistance against earthquake-induced damage. Now, having specified these prior distributions, we then perform Bayesian inference using Markov chain Monte Carlo to find the joint posterior distribution of these variables, which is illustrated here with the blue dashed line and the shaded area. So on the left, you see the posterior of the IM values, which now better captures the actual ground motion intensities. And on the right, and even more importantly, we can recover the true fragility functions that were used to simulate this data set. Now, luckily, we don't live in a one-dimensional world, and we also applied the two methods to a real damage data set collected after the 2009 L'Aquila earthquake in Italy. And here the plot in the center shows you the surface projection of the rupture and the locations of the seismic stations that recorded this event. While the plot on the right shows you the distribution of the 56,000 residential masonry buildings that were used for which damage data was available. And yes, it is also important to mention that these residential masonry buildings were classified into 6 different building types, and we estimated the functions for each of these 6 types. Now let's first look at the results obtained from the traditional approach, where we use the median IM as a fixed best estimate. So the plot here on the left shows you essentially a shake map output. So it shows you the median intensity conditional on the seismic stations for a specific ground motion model. And the results on the right show you the resulting fragility functions for 2 building types. Here, the building damage is characterized by 6 damage states, from no damage in the upper left to complete damage in the lower right. Now, in the next step, we compare these results to the results of our newly proposed Bayesian approach. And on the left, you see the median of the posterior intensity measure. And we observe that the spatial pattern is now much more refined, especially close to locations of where survey data from building is available, like illustrated here by the small black dots. And importantly, if we compare the fragility functions obtained from both approaches, we see that also here the ones from the traditional approach, that is these dashed purple lines, are flatter than the ones from the new Bayesian approach. And the differences can be quite substantial. Now, in the next step, we also investigated the sensitivity of both approaches on the employed ground motion model. As I mentioned before, the ground motion model is required to estimate the intensity measure at the location of the seismic, at the locations of the surveyed buildings. And for the traditional approach here on the left, we compare 2 ground motion models. And we see that this approach uses the median IM as a fixed best estimate. Thus, it is not surprising that this approach is quite sensitive on the used ground motion model. While the new approach, which accounts for the ground motion uncertainty and performs a Bayesian inference, is much more robust with respect to the used ground motion model. This can also further be illustrated by using again a one-dimensional transect through our case study region. So this dashed black line in the left plot and in the zoomed in version in the upper right is the transect where we're focusing on. And the plot in the bottom shows you the estimated IM values conditional on the station data and using the 2 different ground motion models along this horizontal line through the case study region. And we observe, first of all, that the uncertainty, that is the shaded area, is quite big even after we consider for this seismic station data, especially if you consider that the vertical axis is in logarithmic scale. However, it's also important to note that the median of one model is well within the range of the uncertainty range of the other one. This highlights the importance of accounting for ground motion uncertainty when estimating fragility models. Now, if we go one step further and we look at the posterior IM that is obtained from the Bayesian procedure, that is after accounting for the damage data, we see that the ground motion estimates from both approaches tend to converge, especially in regions where we have many surveyed buildings, where in areas with no or very few damage results, the differences are still there, of course. And this also explains why the resulting fragility functions are more robust with respect to the used ground motion model. Now, to sum up this talk, I think the proposed Bayesian approach that accounts for ground motion uncertainty really avoids the overestimation of the fragility function dispersion that we saw in traditional approaches. And equally important, as we just saw before, it is also more robust with respect to the used ground motion models. And as we saw, the differences between the both approaches can be quite substantial. And I think if regional risk models use such empirically derived functions, then the outputs can also be substantially different. And based on these results, I think it would be worth to consider a potential recalibration of such functions, or to see the differences if one would use a Bayesian approach, such as the one that we proposed in our paper. While this Bayesian approach really deals or handles the ground motion uncertainty part in a quite principled way, there is, of course, much more to be done in the broader sense of empirical fragility modeling, or even fragility modeling in general. Two topics that came into my mind were, for example, a more advanced handling of building characteristics. Because right now in common practice, we categorize them in broad classes of building types or vulnerability classes. But there could also be a more advanced method of accounting for the individual characteristics, like number of stories or construction material and so on. And then another point is also to make the method more flexible, such that it can also handle data sets which have continuous quantities like repair costs, instead of the discrete damage states that we used so far. And finally, I would also like to mention the open source Python package basefrag, which supplements the paper in Earthquake Spectra. And while it also provides the code to reproduce the results shown in the paper, it also provides really an implementation of the proposed method, which analysts can use on the data sets that they have at their hands. And just to give you maybe a quick overview of the software, essentially what an analyst needs as an input is, of course, data on the seismic stations, then the rupture characteristics, and obviously the damage data set at hand. And then one would typically use an existing ground motion model library, such as the one implemented in OpenQuake, to produce IM estimates at the locations of the buildings and the seismic stations. And this is then used as an input to basefrag, essentially, which puts on top of it a spatial correlation model, and it allows the user to specify some prior distributions for the fragility functions. Then it performs Markov chain Monte Carlo to give you the joint posterior distribution of the intensity measures and the fragility parameters. Now with that, I think I'm already at the end of this talk, and I thank you for your attention. And I'm happy to take any questions, obviously.
Thank you, Lukas. That was a great talk. Okay, so I think we're now going to transition to the Q&A portion of the webinar. I don't see any questions in the Q&A chat at the moment, but I have a couple of questions, so we'll get started. As a reminder, if you have questions, if you could type them up in the Q&A feature, then we'll post those to the two speakers. Please specify who your question is for. So I'm gonna go back to our first presentation and I have a question for Yvonne. Great talk. I was wondering if you can talk about how the assumed distribution of patient types, right? You talked about a different set of types of patients that might be arriving at the hospitals, and when they arrive. I was wondering if you could compare that in your study to some of the different historical events that you had discussed, right? Because it's that distribution of patient types and when they arrive, it's probably pretty critical, right, to the outputs of your model. So I was hoping if you can, discuss what you assumed in your study versus all of those different historical events that you had referred to at the start of your presentation.
Great. Thank you, Carlos, for this question. Well, we proposed this distribution based on available data, on all this new data on epidemiology after earthquakes, and especially after for immediate injuries. So what we did was like a kind of average. We calculated an average distribution based on all distributions reported that have been documented in hospitals after earthquakes. And we really tried to select this data on hospitals that were like in crisis scenario, that they were like near the epicenter when they were not destroyed. So it really represents like very critical scenario. So we took all of these distributions, because there are so many papers from the emergency medicine with this kind of distributions, and all of them were consistent with the same distribution regarding the most frequently recorded the surgical injuries on limbs and in extremities. And for example, the crash syndrome was also recorded in most of the recent events. It was between 5 and 6%, and we are considering 5%. And then when we were in Turkey after the earthquake, we learned that this could be very, very high, a very high percentage. For example, in IT and in Turkey earthquake from 2023, it was above 10%. So in those particular cases that have been like very destructive earthquakes, it would be different, and maybe different resources would be like very used or very requested. But if you see it from a general perspective, it's like an average distribution that represents like all the big group of recent events. So we hope this represents like the expected scenario.
Okay, yeah, thank you for clarifying that point. A question for Lukas. Also, great presentation. There are a number of studies in the literature that compare analytical versus empirical fragility functions, and typically these find that empirical fragility functions are flatter, right? They have larger dispersions. So do you think this is because they're not accounting for ground motion uncertainty, as you were alluding to in some parts of your presentation? Or what's the key difference between analytical and empirical fragility functions?
Yeah, thanks, Carlos, for the question. Yes, I think it's a very good question. I mean, I think there are two parts in this answer. So one is definitely it has an effect. So if one would include ground motion intensity, I would expect that the functions become less flat, and then they compare probably better to analytically derived functions. But of course, there is also a huge difference entirely in the methodology. Like analytical functions, for example, what is much more difficult to achieve with analytical functions is to account for really the distribution of possible buildings in a certain building class, if you want to use it for regional modeling. Because, for example, typically one would assume more or less regular buildings, let's say moment resisting steel frames with different number of bays and what so on, but typically we would not consider torsional effects or construction deficiencies or design errors. And all of these effects are, of course, in the empirical data. That is, on some parts, one would expect that empirically derived functions are a bit flatter than analytically derived functions. And that's why also I think both are super valuable to compare against each other, because they really complement.
Mm-hmm. Yeah.
Yeah.
So building a little bit on that question and the example that you presented, how would you change things if you had empirical observations from multiple events? So damage observations, not just from a single event like you presented in your example, but if you had it from, say, a past event in the same region, or essentially multiple entries, but then not coming from that same earthquake scenario.
Yeah, I think in that case, of course, the computational, I mean, it's going to be computationally more demanding, but from the methodological point of view, it's not too difficult. I mean, essentially, you would have two data sets which are kind of independent, where the only shared variables are essentially the fragility function parameters. So while it's not implemented in the Python software package, this functionality, I think it's not difficult to add it. It's more than maybe difficult on the computational side how to handle such large data sets. If the data from multiple events and each one is pretty big, then it can become a memory issue or something else. Yeah.
Okay, but there's potential then to integrate those.
Yes, definitely.
That's great. Okay, going back to Yvonne, you presented a case study that was, focused in Chile, and I was wondering if you could talk a little bit about how, the modeling approach could be applicable to other regions of the world. Obviously, we talked in the earlier questions about examples or assumptions related to the patient types and their arrivals and so on, but maybe can you talk a little bit more about how the way you modeled the operations within the hospital, in particular for emergency treatment, how those maybe carry over to other geographical regions?
Great, thank you, Carlos. Yes, well, first, our processes were defined like depending on the profile of the patients, and it reflects, we hope, very well, like the average condition of injury profiles around the globe, at least for recent events. But they are interconnected with the processes, and the processes were defined thinking about the need for it to be very general and very simple too. So as you see, they are processes that are offered in tertiary hospitals around the world. All tertiary hospitals must have these specialized services. For example, hospitalization, intensive care, dialysis. But what makes it different from specific cases is the thing that some restrictions, for example, for surgery, may be different, and we would suggest that this kind of very little details are modified, and we also have these simulations available from with access, free access for all of you in GitHub. So you can just make these few modifications only if the processes are different. For example, we assume that for surgery, you need a hospitalization bed for recovery and so many days. And that's critical, because when you don't have like the network level support, you'll be like, you'll have so many patients waiting for one bed. And it happens the same with the emergency department patients. For example, we are assuming that if you are within the examination room, you have to wait there. And if you need like imaging resources, you go to take your image and go back to the examination room. And that's a very important detail that can increase waiting times, but it's like a general procedure recorded in different hospitals around the world. But we know that it could be different, and the model should be modified, but it's a very small modification, but that has like a very great impact. We expect that. But yeah,
you can make the change
you can make the change, but it's like conceived to be like the most simple and general model.
Yeah, great.
Thank you.
Yeah, thank you. Thank you for clarifying that. Lukas, back to you. There's a question in the Q&A that is sort of referring to the number of data points and how sensitive your model is to the number of actual data points that you would have for actual damage. Could you maybe talk a little bit about that?
Yeah, sure. Thanks for the question. I mean, it's a pretty good question as well. I think the nice thing about the approach, because it's Bayesian, it actually accounts, of course, for the number of available information. So that we also saw in our case study for L'Aquila, of course, you have different observations for different building types. Like there are, for example, in this case, most of the buildings were masonry buildings, and most of them were relatively old, while there are very few newer ones. So the fragility functions for the newer ones had a larger uncertainty, which is the nice thing about this Bayesian approach. So the results actually reflect the different number of available damage observations, which is typically not possible with a classic maximum likelihood estimation. Yeah, I think that's.
Yeah, thank you for answering that. It was a good question for sure. I noticed we're a couple minutes past time here, so I think we're gonna start wrapping up. I know there were some questions in the chat about the slides, and I'm sure some of the attendees might have follow-up questions, so you might be getting emails from those in the audience. But Elizabeth, I think I'll hand it over to you so we can wrap up the webinar, and then we can connect the audience to the two speakers if they want to follow up.
Great. Thank you so much, everybody, for joining us today. And thank you again to our speakers and moderator. Just a couple quick notes here. There's a survey that will pop up when you leave the webinar, and you'll also get that by email tomorrow. So if you could take a moment to respond, we'd really appreciate that. You can learn more about EERI and join us at our website. And you can also find an opportunity to support this work we do, both the publications like Spectra, things like the webinar series, but also our reconnaissance work in the field by supporting the LFE endowment. And then finally, I just want to acknowledge again our funders, FEMA, the Learning from Earthquakes Endowment Fund, and our EERI members. Thank you, and I hope I'll see you in February for our next webinar.
Thank you, everyone.